So my name is Dr. Jess Wright. I'm the director of the University of Louisville Depression Center, which is a member of the National Network of Depression Centers, which Dr. Greden happens to have founded. He was the the founding executive director of and chair of the executive committee of the National Network of Depression Centers, which is, I think, doing some great work. And you might say a few things about that tonight, John, so I won't steal any of that thunder. But John is a good friend of mine. We've been working together for a number of years, and I've appreciated all of his support in our development of the Depression Center here in Louisville. We have a mission to enhance clinical care. We treat many people here in Louisville. We have over 40,000 visits each year to our center. And we have a big education agenda. We educate medical students, residents, trainees from all kinds of disciplines. We do work in the community. This is an example of one of our educational programs tonight. Tomorrow we have a conference for professionals that Dr. Greden and others are going to be speaking at. And that conference, which is going on now for several years, reaches typically around 200 people, clinicians that learn a whole bunch about how to enhance their understanding and treatment of depression. We also have a significant research agenda, which I won't talk about tonight, but I think Dr. Greden will probably tell you some of the things that are going on in research on depression and mood disorders around the world and in NDC institutions. So Dr. Greden is one of the leaders of psychiatry, and particularly in the field of depression. He's written extensively on treatment-resistant depression. That's a condition in which you're given a good medication or 2 or 3 and have psychotherapy, but you're still not getting better. And he has lots of good ideas on how we might approach that particular problem. He's very well known for his work in organizing the National Network of Depression Centers and leading the University of Michigan Depression Center, which is housed in a gorgeous building in Ann Arbor, full of labs and clinical services, and is making great strides in improving our ability to treat depression and related problems. So tonight, Dr. Greden is going to talk about Depression 2017. Where are we today? And how can we find the best treatment for each person? So let's give a Louisville welcome for Dr. John Greden.
Jess, thank you. And my validity check now. Can all of you hear me? Yes. We're good. Okay, it's a real delight to be here. I can remember coming when Louisville was becoming a new member of the National Network of Depression Centers that Jess talked about. And we'll keep some time for questions and answers. What I want to do tonight is, first, I'll show you that one. I would like to work with you, and I'm going to use a cliche here, almost convey why one-size treatment will never fit all people with depression. 2, to sort of dramatize how frequent, how common, and how disabling these illnesses are. And we've got to do better, because so often we aren't sure what treatment will fit each person's depression. That's the challenge. And I'll try to summarize the progress, and then we'll literally talk about where we go in the future and how all of you can help. And we'll have some questions and answers. You can't see that very well because it's up there. This is obligatory when doctors give talks, and I have no conflicts of interest. I'm not being bought off by anybody. And what I do want to do now is to just sort of give you the sense that what we're talking about, I don't want to overdo this. I don't want to overdo it, but we're talking about brain illnesses. But our brains are influenced if your basketball team loses in the NCAA final, people get sad. Why? An external event. Something happens. Where does that register? Up there. When people end up having major stresses, when they have traumas, there. And so often what we forget is, because we have a term, and it's a good term, but we talk about mental illnesses, and that's what they are. That's where they are. And I think what I want to do today is to just dramatize to you that these are common, treatable, and if we don't do anything to address that, there's a consequence to be paid. These are very disabling, costly, and burdensome illnesses for family. So I'm going to try and talk to you almost as a research-oriented clinician, and what are we learning and where are we going? First, I'm going to give you a bit of history. For those who care, the profession of psychiatry has had a long history. So at one time, watch the science move forward. We actually used to drill holes in people's heads several centuries ago, a lot of centuries ago, to let out evil spirits, because that was what was seen as causing problems like schizophrenia, depressions, bipolar illness, manic depression, etc. At one time, we wondered about lab tests, and the thought was you could feel bumps on a skull and tell what was going on inside. That didn't quite cut it. We went through an era, and it's still around, of psychoanalysis, and it still does good things. But does it solve everything? No, because one-size treatment will never fit all. Then we moved into an era of research, and this research actually enabled us to start in a way that cardiologists can look at hearts and do angiographies and stuff. You can see what's going on in brains now. You can actually look at functions and figure out some areas that get lit up when things are happening and that aren't supposed to be lit up at other times. And you can look at shape and configuration. And that has created a little bit of a wave that we're very much caught up in, and should be, to search for biomarkers, genomics, epigenetics, all these terms that we're not going to spend a lot of time on tonight, even optogenetics, using light to change expressions in the brain. And ultimately, we're entering into a new one. Everybody out here, I would venture, has maybe got a smartphone in their pocket and other things at home, and we are going to be seeing, you will be seeing, a time when we monitor our variables, how we function, wearing things on our wrist or on our belt. We're going to have mobile monitors, and those will enable doctors to be able to tell how we're doing. How are you sleeping? What's going on with your depression when it's being treated? And the goal, and I'm going to use this term and I'll explain it to you, is that we want to get to a point where we have personalized, precise treatments. So I may play a little game with some of you as we walk through, just to illustrate and sort you out and talk about some of these things. But first, let's look at how important is this problem. We're talking about clinical depressions and bipolar illnesses, manic depressions. And I just was showing you progress, but by gosh, we still have an awful lot of work to do. So let's look at it. That's the individual who is now no longer he's now with Silicon Valley. He's with a company called Mind Strength. And it's Tom Insel, who was the director for 12 and a half, 13 years for the National Institute of Mental Health. And I want to have all of you become voices for this. When you go out, if anybody brings up this topic, how important is it? You can say the World Health Organization has stated that clinical depression is the most disabling, most burdensome illness in the world. Think about that. More than heart disease, more than cancers, the most disabling in the world. It is the second most expensive in America, after only what? Help me out on this one. What do you think costs more? Take a guess. Anybody had a cardiac angiography done? Or those things? Cardiology. The suicides, we're over now 44,000 deaths a year by suicide. And 70% of them, perhaps more in some areas, are linked to depressions. And then, in a way that really is kind of scary, untreated clinical depressions and bipolar illnesses take several decades off of people's lives. So, and that's something that we have to figure out why and what can we do about it. So what are the reasons for these huge burdens? I've said this so often, I hope you go home and take it along. One-size treatment will never fit all. Because, and I'll explain why, because there are different causes. And if you try to make one fit, it's not going to work. We don't know those different causes yet. What Dr. Wright said is really vital for us to do. So how many of you, let's do a little routine here. How many of you have cancers in the family? Most of those hands go up. Now, how many of you have had people in the family or close friends with heart disease? Most of those hands go up. Provocative question. Now, how many people know somebody or have a family member or have personally experienced clinical depressions? And I like you. This is why I say that is so often that's the one that is, it produces this response of, do I really want to raise my hand? And that's the stigma. We don't know as much about these things as, for example, have been learned for cancer and heart disease. Now, if you talk about, I've been using this word and nobody has cringed too much. I mean, I'm talking depressions and bipolar illnesses. What happens is you no longer go to a major medical center and have people talk just cancer. There is no single cancer. It's very different. And now, because of the techniques that are being developed, cancer specialists can sort out the cellular structure and determine which type responds to which chemotherapy. And that's personalized treatment. That's precision treatment. We don't have that because we didn't have a network. So what Dr. Wright pointed out is that we now have one. We started one 7 or 8 years ago. It really sort of got rolling. Started with 16. Louisville was one of the first. And there now are 26, and we're growing. Sharing data, learning from each other, and eventually we'll figure out some of those breakthroughs such have occurred with cancers. This is a little bit of a complicated slide, but I have to use it to explain. So these are genetic illnesses. If someone has a bipolar disorder, that's a term, by the way, for manic depression, the genetic load of that is pretty impressive. And if you started actually to say, for example, that if I have a mom, an aunt, and an uncle, all of whom have diabetes, so I watch mine carefully because that means instead of having a 15 or 20% risk, it goes up to 35%. That's the genetic family type of stuff. Depression is comparable. Bipolar illness, if I had an identical twin with manic depression, my odds of getting it would be 70%, 80%, something like that. This is the kind of stuff that we have to understand because it may help us determine what are the underpinnings of all of these things. But the slide up above just illustrates, I'll just show it to you if I can catch it. Can you see those? All of those things, if you look at genes, circuits, structures, systems, all of that turns out to be active. And they're all going on, and we have various people studying all of those things. Ultimately, we get down to a final label that sort of says depressions, but I need your help. Jess needs your help. All of us need your help. We no longer want to talk about, oh, there's one thing called depression and one treatment. So that's a take-home message for today. The term that I've already used, and that I'm going to just try to explain very briefly now, this slide is a little bit busy, but in the past, if you went to see a doctor, a clinician, a psychologist, they would kind of want to know, what kind of symptoms. I'm calling that on this slide, what's a medical phenotype? What do you show? I just don't feel good. I'm tired all the time. I'm fatigued. I don't sleep well. I've lost a lot of weight. I'm not having much appetite. I stopped doing things that I used to once enjoy. And that's a description. And then if somebody did it in the past, it would be, anybody else in the family had any of this? Because of what we've just discussed, a little bit of genetics and stuff. But we haven't paid very much attention to when we try to seek what's going on down here. Where are we with, how do we measure genetics? What about all of the social stressors? We have, but not enough. Or we've had certain people who've paid attention to each of those, but not to these. Our challenge now, and what we're going to be doing, and what we are doing, is to link all of those together. And then we're going to come out with enough information so that we can characterize these things and say, we have this. Now, you can't read this slide very well. So this is the game time now. So we're going to pretend that all of you, everybody in this auditorium right now, has a clinical depression, some sort. Now, the people over here, you have a serotonin problem. Just these first 5 rows, you don't have that one single neurotransmitter that's working very well. Behind them, you have a glutamatergic problem. That's a different one. You're the ones now that if people talk about ketamine being a new treatment, it may be working on that. Jess is down here, and he may respond to Paxil or Prozac or Zoloft or some of the conventional antidepressants. And then the people back there, that row, you have sleep apnea. You don't have these problems up here, but because of what's going on in your brain, you have a picture that looks very much like what these people do, and it's not always so easy to differentiate just by talking with someone. And over here, there's a cluster of you, a few football players, you had head trauma, and you ended up having some difficulties that actually led you to be depressed. This is a problem now that the NFL is working with. And people back there, you have diabetes, and somebody else has pancreatic cancer. All of you can have a phenotype, as it's called, that looks like depression. But think of the different causes, and then look at that list and figure out how many more I didn't even mention. So what we're talking about is, how do we sort that out? We are going to do it. It's going to happen. And yet, because of that, that actually changes how we do when we respond. So if all of you went in to see a doctor, a psychologist, a social worker, and you ended up getting a certain kind of therapy, the odds are it might be the right one, but it may not. And that's what we're looking for, is precision treatment. This slide, you're going to just have to listen to me walk it through, because if all of you went in now with depression, and we treated all of you with the same type of conventional antidepressant medication and some psychotherapy perhaps, only about 38% might improve. Then we've got to start doing this. Okay, now let's try this, or we'll add this. Well, that one didn't work, so we'll take that one away. That's our burden right now, and that's actually something that has to be counteracted by a statement now. So I don't want to send you home thinking we can't do anything, because inevitably, over time, you can get to the point where you only have about 1/3 of the people who have not responded. We call those treatment-resistant depression. It's not that they're resistant, they just aren't getting better. So that's the group that I've kind of focused on, and a lot of other people have. Putting that together, that's still an awful lot of people. We're talking about millions. What do we do about that? So we search, and we try to come up with the clues that will enable us to actually figure out which treatments work best for which person. Now, when I said millions, I did that intentionally. When I asked you to raise your hands, if any of you knew, that's probably why most of you are here, because we do it. If we look at the entire country of the United States, and it's comparable in Canada and every place that it gets looked at objectively, 1 of every 6 people has depression in their lifetime. 1 of 6. You wouldn't know that often, because this does still tend to, that little phrase there, we don't talk about it very much, but that's changing. You're seeing now athletes and singers, and Demi Lovato runs around and goes on shows and talks about her manic depression. And we're actually getting to the point where there's a great deal of openness. But what we're finding is that 1 of 6 is still not very well known and not understood. So then, if treatments come later, or if there's no diagnosis, we've got a problem. And that's basically what we're really talking about. The symptoms that people go in to see primary care doctors, obstetricians, pediatricians, college mental health or college health people, I'm stressed, I'm not sleeping, or, intriguingly, I'm sleeping too much. With the clinical depressions, you'll find, especially with manic depression, 1/3 of the people actually sleep too much. They just crash and go to bed. And that's not necessarily a good way to live. Others can't sleep. And I'll give you a few clues later on about what doesn't help. Alcohol is not a solution to have a glass of wine before you go to bed. That essentially is a good anesthetic. It puts you to sleep, but 3:30 in the morning you're awake, and that's a time to ruminate. It's no good. But if we looked at all of this, what we're really talking about is not playing tennis, not doing the things that you once did with kids. Treatment interventions literally have to be done sooner rather than later if we're going to solve this public health problem, and we can. But that's why it's so important to kind of pick up on what's going on with me. This highest global burden, I walked through all of this. I threw this slide in only to just toss a dollar figure in. We're talking $210 billion that this costs our society. And I've already pointed out that these are illnesses that are up here, just like some of the others. We can have scarier illness, Alzheimer's, that's up there. These things actually are treatable in a way that we have learned now. If these causes that I was taking off, a few of them, get intervened, people dramatically just start improving. I'm back to my old self. But the illnesses do not select. Depressions and manic depressions, they hit all genders, both genders. There is no differentiation. The age ranges are really important because the age of onset starts from 15 to 24. We don't find them right away. Why? Because we haven't screened. That's even changing now, and the NNDC is pushing this. So what we're discovering, for example, is that if you've got an adolescent who's just withdrawing, having difficulties, no longer playing tennis, I'll give you a little anecdote on that in a little bit. Those are clues. Grades drop, friends disappear. We appropriately, I think, sometimes blame social media. They spend all their time looking at that phone. They've stopped interacting with friends. But clues are there, but the clues are in how people live, and they don't necessarily come walking in and saying, "Mom, I'm depressed. You know, what can I do?" That's not, "Mom, my knee hurts. I heard it when I was playing football." They do that, but they don't do the other. So all of these things have to have a public health approach, and that's why we wanted to do this tonight, because you're going to have to rely on us to look at genes, but it's parents and friends and teachers and ministers and rabbis and everybody else who has to look at stresses, and we've really got to put it all together, and then we're going to solve this. So read the little list up there, and I want to make a few comments about all of these things. If you started to say, when we talk about clinical depression, is it just blues? Is it just, well, sleep. I'm tired. Pain. I hurt. The more pains that people have, the greater the likelihood of depression. And that actually is a link. Why? Pains register again here, and you may have something that's going on, but the whole system gets going. So whereas the energy and everything else, the irritability, the sadness, the change in appearance, you can't see me very well up here. Maybe you can. I can't see you very well because of the lights. But for a while, I actually had fun doing this. People, I can't do it very well without a mirror, but people change expressions. And if you could see me, I can imitate what is called an omega sign. And people will get a certain wrinkle in their forehead because they're always doing that. Because they're agonizing, they're hurting. And it's a psychic pain. And that's actually probably one of the features of depression, that the picture is not an especially dramatic one, but you can tell it. And now, in the way that I alluded to this earlier, some of the research that's being done, you can actually record phones. And is there a difference if I'm depressed. Yeah, I don't know. Yeah, I don't want to do that now. And having somebody else say, what are you doing? What are you making for dinner? That really smells good. Talking differs, inflection differs. Pay attention to those things when you have somebody in the family, because they're often clues. You'll have people say, I can tell when mom is starting to slide again just by listening to her on the phone. We're recording those things now and actually doing them with companies to try to figure out, can that be automated and serve as a warning sign? Self-medication, not a good thing. I'm probably going to alienate some because people try it. Why do they try it? Why do you go and get to the drugstore and pick up the products that St. John's wort and other kinds of things? Because they don't really want to go to have somebody know that they're depressed. So they can do that one on their own. But the science behind most of the over-the-counter products isn't very solid. Some of these things help. So you'll hear me say there's evidence for actually taking folate. There's evidence for vitamin D for some people. It could be measured. And there's evidence for some bipolar people for omega-3s, the fish oil. That's it. When you start talking about the other stuff, the evidence otherwise is not really available. So if we talk about recognition alone, now what do we do about this? We're back to that one. We did it already. And we saw that one. Sorry, did I go backwards? The one thing that I think I would like to do is to just use a couple analogies. Many of you have jobs, you work, or you're interacting with neighbors. We have a pattern that I think when this illness tends to occur, we climb up. And I think that's actually, in a public health way, not a very good thing to have. And people ask me, well, I'm really concerned with my friend, but I don't know what to say. And so I, just for the heck of it, put down thoughts. And if people do have something, you can't walk up to somebody and say, the person that you've been bowling or golfing or doing whatever with, and say, are you depressed? It doesn't quite fly. So what you can do is you say things, are you okay? You don't seem yourself lately. And you don't often get anything back right away, but you end up having things, and yeah, I'm fine. I'm fine. Well, I'm not sure. I've been watching you, and the last 3 times that we've talked about going out and having a beer, you have a reason why you can't. And I'm concerned, and I miss you. I'm actually finding that I go home and I think about you. And I've talked about it with my wife. And I'm here. I'm here to help. And if you need some help, I don't know what to do. I'm not the clinician, but if you need some help, I'll go with you. Sometimes it helps to have company. It's amazing how many people will pick up on something like that and actually take you up on it. So those are clues that are sort of getting there. And yet, when you try to push people, sometimes what we find is that they don't go. What do? They give you reasons. This will handle itself. I've been there before, and they probably have, because these things are episodic and recurrent. It'll get better by itself. Excuse my crassness, those damn doctors, they just charge too much, and you can see the other reasons. Along the way, and I kind of have a little personal anecdote that I have used on occasion for residents, medical students, et cetera, because I remember something. Dr. Wright and I both had a little time back in the day of the Vietnam era when military docs. I was in a situation where, that's just up there as a reminder of this, where I was a psychiatrist on a military base. And I was doing something at that time which was pretty problematic for the country, it was substance use. That was when we had drug abuse was public enemy number one. President Nixon made it a cause and said we have to really do something to solve this. And I did a survey and then several more, and then was working with the military population coming back from Vietnam and other places. And in one of the circumstances where you do these things, I got to know a senior person, basically the commanding colonel of the health system, and he became sort of a friend. And you'd have social functions in parties where they did these things. And I noticed it. I noticed it being he drank an awful lot. And would actually, with help and stuff like that. And because he was the leader, everybody took care of him. And at one point, I was talking about something, and we were talking about substances, and everybody focused on heroin. And I made reference to other things. Afterwards, he came up, and intriguingly, it was a cocktail party, and he had a drink in his hand. And he said, some of what you were talking about drove home. What do you do when that's a problem with yourself? Who do you go see? And I said, you're doing fine. And I hated myself after that because I had an opportunity. He was asking me, I was a young captain then, and I didn't quite have the courage to pick up and do something. It takes courage to still deal with these illnesses because they're still too much hidden, but it's changing, and it's changing so dramatically, and I would like to believe that Dr. Wright and the group here in Louisville and all of the rest of us have had something to do with that because we've called ourselves depression centers. And I think that's partially made the modification. So be open, and you don't have to use technical jargon terms. You can just use the common sense that I was doing. Grandma's advice. This one, Jess told me when we did this, he said, this is a public audience. This is a group that basically, they're not walking in with their PhD or other kinds of things or MSW. It's a group that wants to learn about these things. And I slapped together this little slide. Grandma's advice would say, you're not feeling well, go out and exercise, do some walking, go out and play, And we've learned something now a little bit of science. Exercise turns out to change a substance grouping that we didn't even know existed about 12 years ago. It's called neurotrophins. Neurons, trophic, Greek word for almost growth. These are the plant foods of the brain. Things that we didn't even know. Brain-derived neurotrophic factor, neurotrophic growth factor, fibroblast growth factor. They're all out there now. What makes them go up? Exercise, walk. And what makes them go down? Pain, alcohol, toxins, too little sleep. So that's now being linked to depression. So Grandma was right. Get out there and do some things. And if you have somebody in your family, do it. Reduce stress. Oops, sorry. Did I go by it? For families, have a date night. Do some things that are just sort of fun. Movies, make it a routine. Managing physical pain appropriately is crucial right now because you guys are, just so are we. There were more opioid prescriptions in the state of Michigan last year than there are citizens. Oxycodone, Oxycontin, all of those. This state, Ohio, Michigan, Pennsylvania, for whatever reason, there's an area that's been hit harder than even some. We are really creating a new problem all over again in how we're managing pain. And paradoxically, oxycodone and opioids produce depression. And they're associated with depression. Not a good choice. Limiting alcohol, I mentioned it already. What do people do when they're having trouble sleeping? Maybe because they're depressed. They have a drink at bedtime to help them. Puts them to sleep 4 hours later they're awake, and that's when they have suicidal thoughts, and why am I going on like this? Not good. And then the other things I've already also addressed, but Grandma gave good advice. We just need to be following it. The traditional treatments really are, I think, pretty vital to pay attention to. A little piece of science that goes together. Does counseling help? Psychotherapy, CBT, DBT? The answer is yes, very definitely. Do medications help? Yes, very definitely. Does exercise? Not probably all by itself if there are other things. Does it help though? Yes, very definitely. What we don't have is the stuff that I began with. We haven't got it all sorted out as to who needs what and which. So we still have to work at that. But in the meantime, when you start actually doing these things, since we don't know, the combination seems to work the best. If somebody's sick enough to need medications, they'll also benefit from therapies. And that's actually basically something that over and over studies have shown that the ones that have somebody giving them good advice, telling them why you're thinking as such and you're behaving this way, put it together. Take these medicines, but also go see somebody and work on this conflict that you're having with your boss or your marital issues and the other kinds of things that are on there. By the way, I should ask Dr. Wright before I say this, or Carol, if these slides in any way are helpful to people, you're welcome to them. I don't know whether we can get that, and there are other kinds too with more detail. So there's a phrase that's out there. I don't know that you can see this very much. It's actually been talking to your amygdala. That's the blending of part of the brain. People don't always need to go to see somebody else when you learn it. Actually, Dr. Wright has, for example, a book, and it's actually got a DVD type of pattern, and you can do it online and these things. You can pick up on those things, but there are moments that you have when everybody gets anxious. What do? You say to yourself, if you're a basketball player, when you're shooting that free throw, that's going to determine do you go on in the tournament or do you lose if you make the next two shots. What do? You know, they take that breath, they do things that are actually picking up on, now, how can I relax? And sometimes you talk to yourself, and you've got to say the right things, but when you learn them, don't be afraid to take them into the circumstances and modify your own behavior. It's a lot better to do that than it is to back away from things. I want to give you a few things, and then because I am covering a waterfront with you. But I said earlier, we're learning so much about these things. Stuff that doctors don't even know right now, but we're learning in the field, those who are essentially doing the research and operations like the National Network of Depression Centers. If you end up having 1 of every 6 people, that's a population at large that has depression, clinical depression. What happens if I have diabetes? 1 of 3. What happens if I have cancers? 1 of 3. They overload that 1 of 6. What about if I have heart disease? 1 of 3. What's going on? How do we explain that? And sometimes you say something like that and people will say, well, of course, you would get depressed if you had cancer, or you'd get depressed if you had heart disease. But often it even precedes. And we're learning now that the same things that may actually do damage to a heart are damaging us up here. And those are inflammatory aspects. You can have those immune responses that are changing things and produce platelet aggregation in the heart, and people start clogging up vessels. What are they doing up here? And that's actually now become a testing procedure that we're paying attention to. Sleep apnea, I mentioned. I don't know whether I included it in. I think I should look once, because I'm sort of forgetting. If so, I'll go by it quickly. I'm going to just tell you now. So sleep apnea is when you have a pattern. It's up here, but it sometimes is treated by altering uvula and stuff like that. But people will have a pattern of just not sleeping well, and then they have a characteristic notation that sort of gets picked up on, which is that they'll stop breathing. And they'll sometimes go 30, 40, 50 seconds like that, and then, and they snore a lot, and they're fatigued, and they're tired, and lo and behold, 70% of them have depression, So do you treat it by giving them an antidepressant? Not necessarily. You treat it by treating sleep apnea, by getting a sleep lab and then by getting a CPAP machine, and it works. So these are, again, where if we look at our overall health, we really will be far better off as we address these things. The opioids I've already commented on. I'm going to show you something in that one in just a little bit. But now, I come from Michigan and I grew up in Minnesota. I'll start with my hand. How many of you have at least a minor version of seasonal affective disorder? Okay, that's about right. In certain areas of the country, it gets to be 20, 25, 30%. In other areas, it's 2 to 3. The closer you get to the equator, the less it is. For every 200 miles, it has a week earlier of onset. You start losing energy a little bit, you eat a little bit more, you want to veg out and sit on the couch and eat potato chips and drink beer, and it's almost going into hibernation. And I think the bottom line is that those now turn out to be a new area of science, just to let you know the excitement of these things. Clock genes. We've learned that there are genes that control our chronobiology, the biology of time. And in essence, they regulate us. And when people have seasonal affective disorder, I'm going to move my way off the podium here if I don't be careful. When you have seasonal affective disorder, it is not the same as depression, but it characteristically can accompany that. So if it's a challenge for the doctor. Simply because something gets worse in winter doesn't mean that it's always just that. And that's a differentiation. So people have to ask, what's it like the rest of the year? And there's a lot more complications. It's almost a separate talk. Okay, so that one I've already told you. And this is now the sleep apnea. I knew I had these slides in there. And the stop bang means you snore, you're tired, you're observed to stop breathing, and you essentially have increased blood pressure. I'm going to tell you a story about that because these are very common. And of all of the things that I routinely, I just have it as a part of a situation, but there are people, and we won't do the hand raising on this because you may not even know in this group, who have sleep apnea just by the statistics. I could bet on that. So now if we started to actually say, I saw somebody in a consultation not too long ago. They actually came from about 150 miles away, and they drove up with a friend. And they drove up, they came to our depression center because they had depression. That was the thing. That was a 20-year history. And she had done very well. But then 5 or 6 years ago, her husband died, and she still came back and was doing well. And then about 3 years ago, by history, she said she started to fall apart and really didn't want to go on living. And her friends said, let's go to one of these depression centers. And I saw her, and then for some reason, I just omitted doing what I sometimes, not sometimes, hopefully all the time, routinely do. And I didn't ask this. And I spent a long time with her, and I was all set to try to make some recommendations on medication. She was on the same antidepressant. Her doctor back home had raised it twice in dosage. And it was a question of going up even more and maybe adding something, and that's why she was seeing me. And then I said something about, well, we'll have to work out some way for you to be followed back home. How far is this? How far did you drive? And she said, well, it's about an hour and a half. And I said, that's too far to come routinely. So when are you going home? And she said, oh, I don't know. probably right away, but she said, we had a tough night last night. My friend nicely drove up with me, and this morning when we got up and had breakfast, I said, how are you? And she looked at me and she said, I am terrible. I'm terrible. And I was just stunned, and she said, I did not sleep all last night. I don't know whether you are aware of it, but do you know how much you snore? Has anybody ever told you that? You didn't even hear the person we shared a room, is what she's saying. And she's telling me, you didn't hear the person in the room next to us pounding on the wall twice, trying to get us to stop, this kind of stuff. And do you always do this? And I'm hearing this story near the end of when I'm ready to close up, and I said, we're going to change our plans. You need a sleep lab, you need a sleep lab, and we're going to keep you on the same medications that you are right now because you've had this history in the past. I think you have depression, but you got something else. And she went in and had her sleep laboratory test, and she had very severe sleep apnea. They gave her a CPAP. I've kept up with her right now. She says, I'm back to myself. No change in the medicine. I think she needed that too. Sometimes we have more than one condition. So we've got to do the things. And those are what CPAP pieces look like. They work. They're much more comfortable than what they used to be. And they essentially are there. So I'm not going to talk about opioids anymore. I think I already did it, other than causing depression. But I want to show you this graph. That's what's happening in the country right now. And so in a way of having appeal, these are the deaths from opioids, from drug abuse, from drug overdose. And we have an epidemic going. And be part of the solution right now. And discourage this. One more little clinical anecdote. Jess, how much time do I have?
5 minutes.
Okay. My wife just had a reverse shoulder replacement, too much tennis through the years, and ended up having bad left shoulder, stopping probably on a two-hand backhand, and paid a price. She went in and had the surgery. Surgeon's a friend of mine. He's very good. Surgery, by the way, has worked wonderfully well. When she left, they gave her the stuff, and this is my hospital. And she went home with 50 oxycodone, and she took 5 of them. She had a husband who was saying, what? But also she would not have done it. She's a nurse, and this is a concern. We need to be sending signals that we're overdoing this. Pain is something that's important, and we have to treat it appropriately, but we're not doing it right now with this. And we have a problem. So be part of the solution. And if it comes up in your community in Louisville, go and end up sort of making people have an awareness of what do we do about this. Now I want to do one thing in a few minutes, just to show something, and I should have asked Dr. Wright and others, but we're watching something right now. So that slide that I showed you that had a lot of information on, if you take an antidepressant, only about 38% respond to it. Then you got to switch and add and augment and, and that kind of stuff. And then maybe you can get another 30%. And then you play around a little bit more. If you still haven't responded, now you're starting to be what I do, treatment-resistant depression. Now you're down to, maybe 10, 11, 12% by the next step. And then you find out there's some that are nothing happening with. Well, one of the things that is sometimes a variable is that we have learned now genetically, we metabolize things differently. And so if you took an antidepressant and I gave the same antidepressant to you, you may well have very different responses to it because we have different genes that regulate how we break those medicines down and get rid of them. So I want to show you something. This is now a white male, and there now are tests available. You can do cheek swabs, a little cotton thing on both sides. You can come up with a genetic profile. And it can say you have a certain genetic profile that enables you to metabolize these medicines not so good. So the red, yellow, and green, these are okay. And these, there are some variations. Well, this is an awful lot of conventional antidepressants, but if this person were seeing a doctor and you picked up on one of those that was, well, let's just take the one. So if you go to the top one, fluoxetine, Prozac, venlafaxine, they're common antidepressants. So that person has not very many conventional antidepressants that would work for them. And if you look, that's a very poor metabolizer for the pathway for those antidepressants. Now that you look at somebody else, well, they have all kinds of medicines in the green and only one in the red. So bupropion, Wellbutrin, that person probably should not get because they're a poor metabolizer. So if one's an extensive metabolizer versus a poor metabolizer, you compare those, wouldn't it be nice to know where you were on the first round? And that actually, I don't know that you can see it back there, I'm sorry, but that actually turns out to be, if you looked at the name up above, that's me. I didn't know this, but I did it just as a test to try to learn. I've never had an antidepressant, but I did it to see what I was like. And it turns out to be, gosh, now I've done this enough clinically that I saw those results and I looked at it and I said, oh my God, I don't have appropriate 2D6 because I know what most of those are metabolized by. Oops, sorry. And this is my wife, and she's given permission. So she's in good shape if she were going to need an antidepressant. I gave this talk to the Michigan Psychiatric Society, not the talk, but the slides. And somebody in the audience raised their hand and said, what the hell do your kids look like? And I don't know, we haven't done that with them. But I do know that at this stage, we're heading into something. We are by no means there yet. This is pretty primitive stuff yet. But do these tests that allow you to have so-called pharmacogenomics or pharmacokinetics, which is how do you metabolize or distribute, do they give a diagnosis? No. Do they tell us what's the most effective treatment? No. Do they assess severity? No. Do they give you some clue as to what's going to happen next? No. Do they identify causes? No. But they may help say, you don't want that medicine right now. Or if you get this one, because you're a very rapid metabolizer, you may need double the dose, for example. And those are clues that could really help our doctors. And I think we're moving in that direction. That'll be a first step, I hope. And we'll then learn as we go forward that we can do something that helps not just guide dosage or avoidance of certain ones, but helps us select. And that's precision health. That's precision treatment. So we're getting there. Take these things to your workplace for those of you who work. Advocate for change. Have them invite people in who give talks. Basically, in everyday life, send a message. If anybody does say, I've got depression, say, it's treatable. You just have to go someplace. You got to go to the right arena. Just do it. And I'm going to tell you one more story, and then I'm going to stop and we'll take some questions. The little anecdote story is, in our depression center in Michigan, we have a community volunteers group, and they basically got together and they decided they would do functions, and I would encourage you to do it. They've gotten good. They invite speakers every now and then, and they have a summertime party, and it's everybody jokingly calls it the depression party. And people drink a bit too much, but it becomes, people donate their house and their yard, and it rotates around in Ann Arbor. And it's averaging probably now, started with 75, and now brings in about 250 people for a party. And not this year, but last year, somebody said, John, you should talk to a name. And that person basically told me, we were working out, and she told me a story. I think you should talk to her for the community volunteers. I did, and she agreed to do it. The story was, she said, I had 2 kids. She said, I'm a little nervous, that kind of stuff. I'm talking to 200 people, but she did fine. And she said, I had 2 kids. At the time, they were 16 and 14. We have 2 kids, and 16 and 14, both kind of cruising through life, doing well. The 16-year-old, actually, easy time in school. The 14-year-old, a little bit more trouble. He had probably a little ADD, but good kid. And then my husband and I even talked about this a lot. We just watched. He quit his tennis team, even though the coach tried to talk him out of it. He wasn't hanging around with friends as much. We were just looking at him, and he was irritable, and grades started to drop, and we actually got a note from a teacher. And things were bothering us. What's going on? But we didn't do anything about it. And ended up having kind of an experience that just sort of brought everything to the surface. Sitting at a dinner table, my 16-year-old, being a typical teenager, said something to him, and a probe, an insult, and he threw his fork across the table and broke into tears and said, "Just get away from me, get away from me. I can't stand this anymore. I don't want to see any of you." Proceeded to push the chair back and bolted from the table and headed down into the basement. And, I don't want to go on living anymore. I hate you. I hate all of you. And they all sat. Mother, who was getting a little tearful then, sat and was stunned. And she said, we quickly got up then and followed him downstairs and wondering what's going on. And she said, we went down there, and I'm sitting there saying, get out of here, just go back upstairs, leave me alone. And she said, honey, what's the matter? And at some point, even before we got into anything, the 16-year-old said, dude, you got depression. You got depression. It's an illness. I don't know whether you know that, but it's an illness, and it starts just about the age that you're at. It begins at teenage years, and you keep me awake at night. You're running around in your damn bedroom, and I can't sleep. You're up at 3 in the morning. You've stopped your sports now. You're irritable. This thing that we just had happen up there, that was a joke, and you look at you, you're skinny, you're not eating anymore. This is an illness, it's treatable. I'll go with you, we'll go get some help. And Mom, who is now having tears run down her cheeks, said, we're supposed to be paying attention to the 14-year-old. And my husband is one, he said, turned to the 16-year-old and he said, where did you learn this? Asking him this, and he said, well, our depression center has a program. They came to our school. They deal with the principal and the administrators and the counselors and the teachers, and then they brought it to us, and my job was I had to do something about adolescents who get depression. I wrote a paper. Dude, you got it. And Mother says, we did it. We went to the depression center. 16-year-old's now 18. He's finished a pretty successful year in college, his first year. The 14-year-old is now preparing for going on to school. He's on treatment. He's doing much, much better. My husband and I talked a lot about this, and I suppose that's why Dr. Greden asked whether I would do this. We wondered, why did it take us so long to bring this up? We let months go by before we expressed anything to our 14-year-old, our concerns and stuff. Secondly, we found ourselves actually wondering, would he have listened to us in the same way that he listened to his brother? And third, at this point, is it always just knowledge, or is it something else? My husband is here with me. He's sitting down in the front row. He happens to be a psychiatrist. we didn't lack any knowledge. We just didn't have the courage to sort of do what was necessary. We kind of probably had some clue. And she said, if I'm saying anything to you tonight, it's go get some help when you need it and get others to help you. And there's nobody who's a better voice than a brother, a sister, a friend, a fellow student. So these are peer-to-peer programs. And those are take-home messages that I'm sort of giving you. These are illnesses that are widespread, costly, burdensome. They can be deadly and are treatable. And we're getting far, far better on those as we go. And you've got a wonderful depression center here. So take it and run with it. And I'm going to not show you the last 2 or 3 slides. You can get them when you get these things. So how about if I'll stop, thank you, and let's have some questions. Oh, good questions.
Is the cost reimbursed by your insurance provider, generally speaking? I don't know much about them.
Okay, and nobody even knows what to call them. First of all, I'm not getting any money for these. People wonder. At some point, that's an issue that you end up having, because you're asking. When they first were put out, I started doing this with David Mrazek, who was then at the Mayo Clinic as a research tool, and they were costing me, I would use gift funds to do them for treatment-resistant depression, and they were costing $500 or $600, and that was a decade ago. When the companies, there now are, I think, 4 companies that do them. I was showing you one of them. Mayo Clinic did this, and it's actually nearby you guys. It's in Mason, Ohio, and it's called GeneSight. But that's just one. There are others too. They now cost about $300, something like that. They are paid by some insurance companies, and Jess has his hand up.
I just wanted to say that we are using them in Louisville at our depression center. In fact, if you came into my office today, I have 4 of them in my desk drawer waiting for the patient to come back for the next visit, and we're going to take a look at it together. And often the insurance company covers most of it, and if your insurance doesn't cover, the companies typically have a sliding scale type thing where it's very reasonable. Just to give you a quick case, a woman that had not responded at all, we found that she had a serotonin transporter gene abnormality where she had the variant that's unlikely to respond to any of the serotonin reuptake inhibitors.
An SS.
And it turned out that that's what she'd been treated with.
Yeah.
SSRIs and SNRIs. And so I took a look and I said, why don't we try one of these older drugs? There's one called desipramine. It's active primarily on norepinephrine. Lo and behold, she comes in the next session. She's vastly better. So this is not going to be an answer for everyone, but I think it is a big help, and it's nice to see that we're able to use that here in Louisville and many other centers.
And it's just a first step. So you could stay up, Jess. You can help me answer these questions if you want, but it's...
I just thought I'd give a personal anecdote on what's happening here in our town.
Well, what I'm trying to do is to give you what is almost the public health perspective and the barriers we still face, stigma and this kind of stuff, but colliding, if you will, with the massive and just wonderful progress that's being made. And that's just one illustration of some of the things. The rest turn out to be research, but this is one that's usable now. There are a variety of other things that actually are going to be appearing. I mentioned the phones and this kind of stuff. We're going to watch all of this just explode in the next 5, 6, 7 years. But in the meantime, it's going to be, I think, depression centers that have to help drive that. So question back there?
I've had the testing, and it said that the SRNI would have been a better choice for me. And I tried that, and that really didn't work either. I've had acupuncture, I've had TMS, I've had ketamine. So I've run pretty much the whole gamut of things over a 2-year period. Depression was brought on by loss of sight in my left eye.
That's stress, you know, that I'm teasing, but I'm not.
Yeah, I mean, I'm still working, and I'm trying to be productive and do the things, fighting it every day, fighting the battle that probably a lot of people in this room fight every day. But at what point do you look at ECT, or is that the only other thing that's left out? I mean, I said EMS, ketamine, acupuncture, SSRIs, SRNIs, haven't had any of the older drugs that you mentioned possibly, which is maybe another option. But when do you draw the line in the sand and say ECT is a really good possibly option? How safe is it, and what's your thoughts on that?
Okay, so I'm going to do something mostly just because I know you understand this. It's dangerous for somebody on a podium in a talk to sort of pretend that you can also be the clinician. One, you're doing the right thing by actually pursuing. It sounds like you've had some really good help because you ticked off an array of things. Two is, I'm going to answer your question, and then if you have some more, we can talk later, but I didn't talk about ECT, but it's still there, believe it or not, for all of you who probably have the stereotype. The most effective treatment we have for the most severe depressions still is ECT. It ends up having its most effective outcome rate, better than any of the individual trials with antidepressants. And it has its problems because there's memory loss during the time period especially that you get the ECT. Not necessarily that persisting over time, but often people can't remember very much for that 2-3 week period. And the history is worth hearing, and I'm going to waste a minute or two of our time. The people who invented ECT, so to speak, were Cerletti and Bini. And they are two Italian psychiatrists at the time in the 30s. So go back into 1937, 38, whatever. And they were in an old times. Yes.
Okay, I'm sorry to interrupt.
Yeah, oh, I'm sorry. Yes. Electroconvulsive treatment is the ECT, electroshock treatment. The interesting thing about it is that they were in a state hospital at the time, chronic people in hospital with very serious conditions, and they noticed that some people who had a seizure for other reasons, medical reasons, temporarily got better with their psychiatric problems, and that was puzzling. And they noticed it enough times so that it was, maybe we could produce a seizure and it would actually produce good outcomes. Well, first they tried patches. They were using camphor patches, but they couldn't control the duration. Then they thought, what about electric activity? And lo and behold, became somewhat dramatic. They then had to select in a personalized precision way. They were trying it with people with schizophrenia. It didn't do so well. They found out with depression, it was sometimes magical. And you can learn to control things now with the new approaches. You can give an anesthetic, you're asleep, you can give a muscle relaxant, you put a little cuff on the leg down by the foot, and so the only muscle twitching that you get is in the toes, and it's quite remarkable. Cerletti and Bini won the Nobel Prize. Nobody ever sort of knows that part of the story. They won it because it really was, in some ways, a breakthrough. It brought things home for the most severe, for people who can't tolerate medications or don't respond or are acutely suicidal or who have other medical reasons. It still is a very good treatment. It's a shame that we had Jack Nicholson in One Flew Over the Cuckoo's Nest, and it scared people away. It's also a shame that we can't figure out still better ways to do that, and maybe we'll get there with optogenetics and flicking lights in people's eyes and activating genes and stuff. But in the meantime, you now have a little bit of additional information on ECT, and if you haven't gotten others, he'll hate me afterwards, but we have a good place over here. You can make some arrangements to have another evaluation. So you had a question in front.
Yes. First, thank you for coming. It's been a very interesting talk. My question was related to, you often spoke about stigma, and you spoke about it in sort of an active way or conscious avoidance. Do you find that most of the stigma attached to depression is still a conscious effort, or do you think it's, for lack of a better term, an unconscious thing, particularly with self-medication and whatnot?
So elaborate a little bit, you know, because what I was referring to is stigma can be, you know, self-stigma, but also society. You know, there are certain things that I don't want anything to do with that, you know, or we're embarrassed about or whatever, and depression still has some of that. And that's what I was trying to refer to. Did I understand your question? Yeah.
Yeah, no, and as a person who's gotten some of that stigma thrown at me, I certainly agree with that. I think I was thinking along the lines of going to the store and purchasing St. John's wort, or using alcohol
Yeah.
as sort of a conscious way to avoid mental health services. And I guess on a personal level, I found myself self-medicating, and it wasn't really a conscious effort. It was just a suddenly found myself, let's say, at the deep end of the pool without quite realizing how I got there.
Yeah.
So I was wondering, is one more than the other? Or?
Well, I don't know whether all of you, at least in the back, could hear some of that, but what one's asking is what makes us do these things? And if you still go back, why is it that psychiatric facilities used to be put out in the country and not part of main hospitals? And why is it? Because these were illnesses that were, they scared people. If you have the homeless person on a street corner who's got schizophrenia and is a psychotic and is, you know, talking to God and that kind of stuff, these are all issues that are problematic. Society hasn't gotten past all of that, and we have to work on it. So I'm not sure I'm addressing this very effectively, but I'll be glad to talk with you afterwards. Let's do it. Question?
Do your centers ever look at EMDR, eye movement?
I know what DMDR is. Some are. I think the ones in San Francisco have done some of that. I don't know that you guys are doing any. We're not.
No, we refer to clinicians in the community that do that. That seems to be the
Yeah.
desired or needed.
Okay, we're going to never, I can tell that Jess was trying to say that.
About time for 2 or 3 questions. We have to wrap it up.
Okay, DMDR, there are various approaches when people are trying to do things, and the suggestion is that you can, by changing facial expression, you can probably change the feedback in brain. By changing eye movements, by giving exercises and stuff, you may have feedback patterns that alter the circuits that we have and change mood. And all of these things are being looked at. I don't know that that one will turn out to be the real breakthrough approach. That's just an opinion by looking at the data to date, but people have tried to do lots of explorations. The Chinese still use acupuncture, and these are things that I think we're still exploring. I think the mainstream approaches that we're talking about here are the ones that were selected for talks like this and the centers simply because they have the best evidence. But we have a long way to go yet, and yet this is just accelerating like crazy. And what's nice, by the way, just as a sidebar, is that the Silicon Valley world has moved into this in a big way. They actually, I mean, I have a daughter-in-law who has type 1 diabetes, and she's had an insulin pump for 30 years, well, 20 years maybe. And you can have automation that enables you to control things and get better. We are going to get to the point where devices are available to help us manage stress and monitor sleep and that kind of stuff. So it is stuff that's exciting. It's on the way, and join in. So, and I can
Time
tell
for one
that's
more
my
question?
Oh, one more.
I think there were some other hands. Are there? There we are, in the front row.
Of the population that is the depressed population, what percent are diagnosed as bipolar? And has bipolar increased the rate of, has there been an increase in the rate of diagnosis for that condition.
So you had two questions for those in the back. What percentage of those with mood disorders, I'll use that term, we cluster them sometimes and put them together. And what percentage are unipolar or major depressive disorder, and what are bipolar? Bipolar, by definition, simply means two poles. And depressed people, the conventional depression, just get depressed by and large. The bipolar people sometimes are hypomanic, a little less than manic, bipolar 2, or they've had full-fledged mania, and they're grandiose and talk too fast in the world is as wonderful, or all of the stereotypes that are out there. The percentage, to answer your questions, is that if you have roughly 21% with a lifetime prevalence, in your lifetime are you going to get this, starting in those adolescent years, about 19 to 20 of that are depression, and 2 to 3% are the manic depression or the bipolar. So it's a lot less. It is also got a whole different treatment course. The emphasis on bipolar is to stabilize mood, prevent recurrences, because they have cyclical patterns. It's true for the depression too. But did I answer?
Well, I think Dr. Greden has brought us a real message of hope. As I was thinking back over my journey in psychiatry, which started roughly about the same time, we had no evidence that any psychotherapy worked for depression or any other psychiatric illness. We didn't have any drugs like Prozac or Paxil or Effexor or any of those. We had no transcranial magnetic stimulation.
That's right.
We had no ketamine, and we certainly didn't have genomic testing where we saw these panels of things that could be done. So what will the future bring? We can't necessarily predict, but I think it's probably going to be some good things for people that suffer from these conditions.
And I'm going to do something just for the heck of it, if you bear with me. That was the last slide that I was going to show you, and then I thought it'll just make me talk a little too much. So looking ahead, we ought to be asking, why do we not talk like cancer? We do studies for 8 weeks, and we say that's a response. Let's talk 5-year wellness, or even 10-year. Why don't we have routine maintenance? When people get better, if they got better with a medication and with CBT, don't stop it. If it ain't broke, don't fix it. And when people get well, stay with it. The reducing rates of treatment-resistant depression, which now averages 30%, that's my target. We haven't made progress. Let's do things that bring it down to 15%. The NNDC patient registry is the type of stuff that will help us get there. We're hoping to have 10,000 by 2020, maybe more. And then let's have biomarkers that enable us to choose. You are going to get better with this treatment. You will get better with that treatment because you're different, just like cancers. And finally, let's reduce the suicide rate. 20% by 2025. That's actually something that's a campaign of the American Foundation for Suicide Prevention right now. Those are some goals. We can reach them, and it will be much better. Final question.
The TMS, I didn't catch that before. So TMS is now regarded as a standard treatment?
TMS is, this will be our last one.
Yes, it is. I left a lecture this afternoon. We have Dr. Comtoy from the University of Washington in Seattle here. She was doing presentations, and she's going to be here tomorrow also. And I had left that to go participate in a transcranial magnetic stimulation service of one of my patients. So we're doing it here in Louisville. And it is approved by the FDA, and some insurance is starting to cover it. That's been a problem, but I think there are going to be more and more. So it offers hope for people that have treatment-resistant depression. Medications haven't worked.
It's like sitting in a dental chair, and you can get calibrated according to your own parameters, and basically it's an attempt to try to give a magnetic stimulation just with a little device that is not like electroshock treatments, not having the seizure. And you get up and walk out after 45 minutes, an hour.
Yeah, so we've heard it doesn't work for everyone, but
right.
it does have a substantial relief for many people. So it offers another avenue another reason for having hope. So I think we need to wrap up, and thanks to Dr. Greden. Let's give him a nice hand. Thank you.